Let's turn our attention to looking at adrenergic drugs and specifically focusing on drug classes. That's the useful way of thinking about these because there are a number of specific drugs that fall under a given class, but if you understand how they're organized, it makes it a lot easier to follow, particularly as they get updated. Let's start with the agonists, and so these are the drugs that basically will act like norepinephrine or epinephrine, depending on the site, and they boil down to being two different types. One that are direct acting, meaning that they bind to the receptor, and all of these are reversible binders for the most part. And the key here, if you go back to our discussion of receptor subtypes, this is where the information becomes useful because these drugs are defined by the receptor specificity, or in some cases, like epinephrine, a relative non-specificity. That is, they will bind to one degree or another all subtypes of the adrenergic receptors. And the others are the indirect acting agents, and basically an indirect acting agent is anything that will increase the endogenous neurotransmitter. And so I'm not going to define which one it's norepinephrine or dopamine, increased locally, meaning within the synapse. And we can do this by either stimulating their synthesis and release, in some cases kicking it out of the granule, if you will. But we won't talk a lot about those drugs in this unit, where we will spend a little bit of time just mentioning the reuptake drugs, the drugs that inhibit reuptake of norepinephrine, for example. These are drugs that are important in behavior modification, and that you're hearing about in a different place. But I simply want to be complete in our understanding of how we can increase the agonism effect related to the adrenergic neurotransmitters. Now, we'll be spending a lot more time talking about direct acting agents, but I thought it'd be worth mentioning the mechanisms for indirect acting adrenergics and give you some examples. And the first one I'd offer up is the drug cocaine, which is blocking the norepinephrine reuptake mechanisms, so the NET transporter, norepinephrine transporter on the presynaptic membrane, and that allows flooding of the nerve terminal with the catecholamine and massive effects quite globally. We also have drugs that will increase the release of catecholamines, and amphetamine is an example of this. Occasionally, this drug is used to try to increase alpha, particularly alpha receptor agonism, to increase attention in a dog, or sometimes to increase the urinary sphincter tone. But these are rarely applied this way because of obvious potential abuse. More commonly, we'll see the use of drugs that are called monoamine oxidase inhibitors, and aldapurinol, so that's a monoamine oxidase B inhibitor, and this monoamine oxidase is involved with degrading dopamine, and so by inhibiting it, we can increase dopamine levels and increase dopaminergic transmission in the central nervous system. And this drug has been approved in dogs for senile dysfunction in dogs, and also improves urinary tract incontinence, for example. Turning to the antagonists, we can break those down on the alpha side as non-selective, meaning alpha-1 and alpha-2 are being blocked, and the prototype for this one is really phentolamine, but the one that we occasionally still use in veterinary medicine is an irreversible, non-competitive drug called phenoxybenzamine. And what we mean by irreversible is that it actually covalently binds to the receptor, takes time for its action to become complete, and it takes time for it to go away. and therefore, if it's often has been used for the treatment of urinary urethral spasm in cats post urethral obstruction, but now that has been to a large extent replaced by a drug below, which is more specific and reversible, called prazosin. We also have other drugs that are antagonists that are reversible and competitive. And I simply would note that, and we'll talk about this later in the context of epinephrine reversal, the phenomenon of epinephrine reversal, the phenothiazine tranquilizers basically have alpha-1, alpha-2 antagonistic properties. And because of that, if we get hypotension and try to treat with epinephrine, we can lead to this condition called epinephrine reversal. So take a look at that in the last unit. Prazosin is a alpha-1 specific drug that's come into its own for congestive heart failure to reduce preload and afterload, and also to manage high blood pressure. Remember, the alpha-1 receptor is associated with the blood vessels, which have the dominant tone, sympathetic tone, in the major arteries. And the benefit of using an alpha-1 specific agent is that you're not also blocking the alpha-2 receptors, which are involved with some of the baroreceptor response on the heart rate. And so that's an advantage in this situation. The selective alpha-2 agents, so those that are basically going to reverse an effect on of a tranquilizer, such as xylazine, would be yohimbine. So let me go a little bit more into that story about the benefit of having an alpha-1 antagonist when we are trying to treat reduced preload in a congestive heart failure situation. We want to do that with an alpha-1 antagonist that is going to help reduce the resistance in the major arteries of the body, and when but we still want to sustain the baroreceptor response. And if that baroreceptor response is set up so that it sends back a signal when we get low blood pressure to the heart to increase its activity, and that's done through a presynaptic alpha-2 receptor, and we've blocked it, then we've basically reduced the ability of the animal to respond to a hypotensive episode with a baroreceptor response. So clinically, we much prefer to use, and most of the time, for most situations, we prefer using a specific agent, in this case for the alpha-1 receptor. So we don't get reflex tachycardia that will then accompany the vasodilation caused by non-selective blockers of alpha-1 and alpha-2. Let's turn to the beta adrenergic antagonists, and all of these are competitive antagonists. There are none that are irreversible or non-competitive in this category, and basically the drugs in this class, just like the drugs on the agonist side, are defined by their selectivity against a subtype of receptor. That's the most important thing perhaps for you to keep in mind. You know, if it's a beta-1 antagonist, a beta-2 antagonist, and then there are these other smaller features, such as the possibility of partial agonist activity, meaning that at some concentration this drug will also act as an agonist as well as an antagonist. That's an example is Pindolol. And then some also will have a local anesthetic action on general effect on membranes. And the example there is propranolol. Propranolol is a prototypic non-specific beta agonist, and I usually write out, all the receptors that are being affected. I don't like just using non-specific because it kind of don't keep track of the receptors, and this is a good way to do that. Now, the specific antagonist that affects the beta-1 receptor, one of them at least, that's used a lot in vet medicine is atenolol. And so you'll see this is a drug that's very useful for reducing SA node firing if there's a supraventricular tachyarrhythmia, or we'll use it in hypertrophic cardiomyopathy, etc. The beta-2 antagonists, basically, while there's some available, they're not being used clinically, and there's not much to tell you about those. And finally, we turn to the dopamine antagonists, and we have a couple here that are used in varieties of ways in veterinary medicine. Metoclopramide is a nonspecific dopamine receptor antagonist. It has primarily D2, but some D1 receptor activity. Phenothiazines, I've already mentioned, they're being very, while they are tranquilizers in a sense, they also are antagonists against alpha-1, 2, dopamine 1 and 2. And the metoclopramide is a drug that is used as an antiemetic and a prokinetic, and it does this through two mechanisms. Number one, it suppresses the chemoreceptor trigger zone, which is involved with detecting circulating toxins. And the second one is that it is a prokinetic drug. So it helps to move ingesta through the stomach into the intestine, and if you've already passed the pyloric sphincter, you make much less likely the possibility for vomiting to occur. So by the central and peripheral effects, metoclopramide has been used as an antiemetic, a fairly broad spectrum antiemetic. It's keep in mind that it's not a totally selective antagonist, and as a result, we sometimes run into the situation clinically where we might have an animal with renal failure, where we're really concerned about the renal function, and reducing by blocking the renovascular dopamine 1 receptors, we have a tendency to possibly lead to the renal blood flow going down farther. So we just have to keep track of all of our receptors, and that's a general message. Keep track of your receptors, and you'll be in good shape.